So once again, thank you to Amity, thank you to you, and thank you to everybody listening in. It's a pleasure from the United Kingdom on behalf of the University of Bradford, and also, as you know, whilst I'm not actually representing the Royal Pharmaceutical Society, but I'm a national board member of the pharmacy profession here as well. I'm going to give a UK perspective very quickly, and I don't want to bore you with things. One of the key things I want to do here is, what do we have in the UK? What learnings can there be, and how can we make this approach positive in our drive against COVID, which is the COVID world, as I call it, that we're going to be living in now. Very quickly, the UK coronavirus cases as of 4th of May, which was yesterday, now over more than 190,000 cases have been confirmed, with nearly 29,000 people who have died through the virus. Now, you have to remember, just to give you some perspective, the UK as a state is, and I continue to use this analogy, is no bigger than the size of Gujarat. So if you can imagine that was in the state of Gujarat, where I come from, then it's a lot of deaths in comparison. That's the total number of deaths that we have, 28,734 as of yesterday. The change from the previous day was that we have now reducing and looking at a reducing curve where there's 288 patients dying per day, really. So today we're hoping it could be even less. In terms of the confirmed cases, we've gone down to 3,985 this is a day-to-day figure that we can see. One of the key things here is that number of deaths continues to going down on the downward spiral. We've had a very large peak. As you can see, the largest peak was around, just before 10, 11, 12 of April. And then we had another peak just around 20th of April, 21st. And that's had a huge effect in terms of how we are. But you can see there is now a definite downward spiral moving. And therefore, we'll be preparing for that into the next phase, really. I think this is a scary figure, really, for UK death toll close to overtaking Italy as the worst in Europe. Death toll has risen by 288 in the last 24 hours, but it's looking very likely now that we will be the highest in Europe, which is very scary for a small state like the UK in comparison to India. What are we doing now? So we're looking at the test, trace, tracking. How can we address some of this? So it's looking at key workers to trial the NHS tracing app, which was announced yesterday, that will be moved forward once the pilot takes place, and we see the results of that very shortly, really. And what does it mean? It means that everybody has a mobile phone, or those people that do, the majority of people, will be downloading an NHS app that is centralized. It works via Bluetooth, and it will record when two people have the app within 2 meters, which is the distance that we have here, from each other, and they've got to be in contact for more than 15 minutes. It will recognize that, and if one later reports having symptoms, then all other app users they came into contact with significant contact over recent days would be alerted, and if necessary, then they would be told to self-isolate. So this is an app. So this is a test, track, and trace presentation. So now, as we are approaching into easing lockdown, so this is the next phase. We want to make sure that we can test, track, and trace as many people as we can, so that we are ahead of the curve. We need to look at the comorbidities. What about the comorbidities? Have we looked at COVID, an outside COVID world, really? We have to remember that patients do have other conditions, and we don't want them to be ignored. And this is something I'm very passionate and keen to drive forward in terms of the messaging. People have long-term conditions, diabetes, cardiovascular disease, mental health problems. Or it could be still respiratory, it could be asthma conditions as well. We do not want to allow them to fall off the track in the midst of COVID as well, and the complications that could lead to. One of the other issues that could have is the access to services as well, because people may be reluctant, thinking everything is COVID concentrated. It's important we don't neglect the management and supporting the management of these long-term conditions, and diabetes, cardiovascular disease, all those can then, whilst there's no causative effect of or substantial evidence show that diabetes, those people with diabetes are more vulnerable to COVID, but there is clear evidence that those people with such illnesses, such disease, have more likelihood of becoming critically ill if they contract COVID. So therefore, it's equally important. There's also perceivably reduced access to pharmacy and medical services as a result of this. And is that because there's a mindset? Is there an issue here where we think, let's not bother the doctor? This is the mindset that we have in the UK in some groups of people, elderly, young, middle-aged, every corner. But because the hospitals, doctors, the whole traffic is focused around COVID, then people have stopped. In some part, there are reports that there's a less referral to from the doctors, we call them general practitioners, GPs here, to hospital because less people are coming forward. And it's the same with the hospital, making sure that the priority is around urgent cases, particularly for COVID cases. So to make capacity, then we're having to move around. And for things like knee operations, things like that could be then curtailed for a little while until we get over the COVID traffic. This is an example that shows that GP, the doctors, urgent cancer referrals decline by more than 70% as fewer patients come forward. And this is where a pharmacist can play a big part, really, that within the local community pharmacy, we can share that, look, if you have anything that is untoward, you may have some feelings, it may be a lump that appears that you've been neglecting. Do not stop thinking that everything else continues to stop, but it doesn't, because you have to realize, you have to continue with, world goes on, it's not just COVID. And therefore, you have to ensure that all the other symptoms and conditions that you would normally go to the doctor should not be ignored in case there's some fatalities there. And we've had cases where people have had strokes, minor strokes, mini heart attacks at home, and the last thing we want them to do is be ignored by their own wish or reluctance to come forward, because as we all know, there could be a longer term damage behind that as well. So don't delay. If you have any problems with your health, then continue to seek medical advice as you normally do. And that's something that a pharmacist can play a big part in. What's the highest group that is affected in the UK? As you can see, I mean, initially the hospital admissions and the death rates in hospital were the highest. But as we move through the COVID curve, we now see with more evidence that people in care homes have actually got the highest death rates possible, with nearly 40% through COVID. And it's this elderly population that we need to work with longer term, as well as immediately in terms of making sure every life that we lose is one too many. Every life that we can stop losing is one that we can prevent. Let's not delay on that. The other, and partly the care homes problem was the delay in testing, people being discharged to care homes without the adequate PPE equipment within the care homes as well, and that and care workers were moving in and out of homes so that they were passing the virus along. So this became a huge problem, and we're now seeing one of the largest death rates within one area, which is the care home. The other part is what we call the BAME group, the Black, Asian and Minority Ethnic group. That includes us, people from India, Pakistan, Bangladesh, Sri Lanka, and also the Black, African, African Caribbean people as well, really. They have the highest mortality rates through COVID. And there's various reasons for this, which I'll go into. If you look at it now, the doctors are calling for action after 125 of this lady's care home patients die of COVID. And it's important that we're now pushing for better funding, more tailored funding, more appropriate funding for care homes and their invaluable workers in order to go forward with. These are the number of people, these are just some of the faces that we see have died from a minority ethnic group. So this is from the Black, Asian and minority ethnic group. Bearing in mind the percentage of population at the last census, which is 2011, 14% of people from the BAME group are representative of the UK population. And yet, 1/3 of the patients in ICU who had died were Black. 1/3 of the patients were Black and minority ethnic group. 63% of those patients of healthcare professionals had died. 44% work as medical staff. So these are the issues. 1/3 of patients in ICU are Black and minority ethnic group. 63% of the BAME group are healthcare professionals who have died, and 44% have medical staff who are of BAME. Within the pharmacy profession, 3 pharmacists have passed away who are of Black and minority ethnic group, and totally 4 have died on the front line. In fact, it's including pharmacy staff. In fact, that's 5. This is a graph showing the variation, and as you can see, it's plotting the number of registered deaths per 100,000 in England by ethnic group. And you can see the largest proportion in the Black, Caribbean, Indian, and other ethnic groups. So there's an exponential increase almost as you go along in terms of the curvature compared to the white population, which is halfway along the slide deck, as you can see. 9% of cases couldn't be identified. It's important to know that. And these are the data that's been produced by the Office of National Statistics for England and Wales. Coronavirus. So one area, Somerset area, have now prioritised the BAME staff for testing, and there is now pressure on the government. The government are now putting a think tank and reviewing why have we got the largest number of people who are dying from COVID and affected by COVID. And so the full details of that have just been sort of circulated yesterday as who belongs to that think tank and what are they going to look for. This is looking at underlying conditions, where they're working, what was their history, and obviously in terms of their ethnic group as well, really. I think I need to mention the fact that with Ramadan being here, we've been very active. Pharmacy plays an important role in Ramadan and fasting because we have a high number of followers of Islam that are fasting. And through that, it is important to advise, as you know, the Quran and the Islamic scriptures clearly say you should not be putting your health at risk. And that's where the pharmacists can play a big part in terms of fasting. Not to say that don't change your religion, but just to support them if they do continue to fast, not to put their health at risk. And if it's something like diabetes, it's also absolutely essential to mention to them that they shouldn't stop taking their diabetic medication. And if they have, they should be working with their doctor or their nurse so that the regime is altered accordingly. One other thing with Ramadan is the fact that when they break fast in the sunset time for iftar, then what we still have in inner city areas is people where they congregated, if they're neighborly, whilst there's total lockdown and they should not be going, some people may still think and believe, well, it's only across the neighbor, it's fine. And I think that message in India should resonate so highly because you've got the villages, you've got, and if they're continuing, if they insist or persist to do that, then there has got to be clear message around that. So we've issued various pieces of guidance, guidelines to support those patients, where I was on one of the news programs yesterday talking about the fact that how can we support people who are fasting during Ramadan. The messaging has got to be right. The community leaders have got to put that message out, work with the communities. The pharmacists can play a role here as well, and obviously the imams as well. What are the factors linked to high death rates in BAME groups? I mean, there's various things that, like I said, it's interesting that what we have in the UK now is the people of most deprived areas are at risk. And it could be due to the high level of heart disease, diabetes, hypertension, the poverty. Is there a genetic factor there? We need to look and we need to test. A lot of the BME people are working low-paid work. So are they more targeted in terms of, they might be delivery drivers, so they're more exposed? And this is where we need to, there is no fast evidence. Correlation is one thing, causative is another. So we don't know really if being a BAME is a causative factor. But the one thing is that if you have hypertension, heart disease, diabetes, obesity, it's increasing your risk. We know through certain communities, the Bangladeshi community, the highest levels of heart disease, lowest levels of literacy. So these are groups that we need to continue to support in a manner that they can relate to. Mental health issues are key, and where are we? Look, so we've done various things, and I'm going to talk a little bit about post-COVID as well. Then have we considered mental health issues really? That's for staff. Has your team, how are they affected? You know, I've been working very sporadically, or helping out on the front line, and I see the morale is low. Their family members might be affected. Who is looking after them as well? If you look at the doctors, they're on the front line just as we're all frontline people. And the stress and the strain is huge. And if you look at the community pharmacy side, people are coming in droves, have been, thinking they're not going to get their prescriptions on time. There's going to be a lockdown. Can we get our paracetamol? We need those. So there's been a huge surge in the traffic and the volume that community pharmacy have been having. That's caused stress. That's caused a delay in a pressure on the delivery system, the chain for getting medication as medicines as well, and the supplies. And so therefore, if they're not able to supply, then that means they have to come back and they have to go back to the pharmacy has to refer back to the patient saying your medication is here. All the system that we have in place adds to that burden really, and a lot of stress. And then you may have lost a close or loved one within your family or friends that's causing the issue. And what about the minority ethnic group? Because we work as extended families, because we work with communities, because we live with communities, because we live with extended families, then how is that mental health going to be taken care of? But it's not just the BME group, it's the white population as well in that perspective. And how can we support the communities? And one of the key things I would want to highlight is, let's plan now for post-COVID, if ever there was a post-COVID. In my opinion, I don't think there'll be a post-COVID, because it'll be like one of the where as a world disease, total eradication of smallpox, etc. And will we ever eradicate it now because of the different mutants and the variants that could be developing as well, and the resistance? So I think we need to look at the people who are left with suffering from COVID and the effects and mental health problems, their long-term conditions. Has their diabetes regressed? Has their heart disease gone worse? Has their blood pressure not been managed properly? And then on top of that, you've got the stress and strain of trying to deal with this. The post-traumatic stress behind this is going to be huge. And perhaps pharmacy, I feel here, but how it extends to India, we'll be looking at how we can work with communities. Is there a role for pharmacists to support provide the network to signpost effectively and work with these patients. This is something that we as the Royal Pharmaceutical Society have been pushing for our profession, to give access to national mental health hotline support. And now we are included as part of the National Health Service team, which we've had to fight for pharmacy to be recognised, along with the other healthcare workers, to access equally support for mental health issues for pharmacy and pharmacy teams. This is the death rate falling in hospitals, but now rising in care homes, as I had mentioned. What are we doing to support that? What is the Royal Pharmaceutical Society doing to support that? And what have we done? Well, there's a huge array of things here. If you look at the Royal Pharmaceutical Society website, and again, this could be something that we can share and support, I think that we can develop and tailor to India's needs itself, really. I think one of the biggest factor that we need to make sure is that we learn from COVID. But by learning from COVID, we're also looking at the fact that through COVID, we may have a new world for us to work more effectively, to be seen on the front line wider, and be appreciated and acknowledged for what we are across the healthcare professions, as pharmacists being frontline, putting their lives at risk, putting their profession forward, and to serve the community and the patient. And that's why we are proud of what we do. So these are some of the, I won't go into it, we've only got a few minutes, but some of the things we support. We've got a whole website full for supporting our pharmacists. What happens in an ethical dilemma? What happens if we can't supply without prescription certain medication, and we can supply a short amount of supply, but what happens if they can't get out for longer, etc.? Can we ease the rules? But we need to put the patient first, and there are processes behind what we need to do to ensure that we've acted professionally, responsibly, and safely for the patient. As you know, the COVID scenario is changing week by week, day by day. So you can see the number 19, if you look at the bottom box, the orange box where it says clinical resource for COVID-19, that is a continuously up-to-date resource package for building up your skills during the pandemic. We use social media a lot in terms of getting message out and joining and engaging with everybody, including other healthcare professionals, and Twitter, Facebook, and live chats. We do lots of webinars. We also produce people who are coming into work, who have retired and who have been on maternity leave, support packages for them as well, so that they come back to speed very quickly in terms of dealing with COVID. So, and there's some clinical resources, whether you're working in hospital, we've got people working in surgical wards as well, in intensive care units. What about pharmacists that want to move into that? How can we support them? And those are all guidance on what to do. Information for the public is important. We continue to stress that, and how we manage some of the services. We campaign, and there's lots of campaigning for coronavirus. We have a whole support team that is on the end of a phone call if anybody needs any advice or questions answering. We work with the government, you can see on the bottom box there, with the NHS. So we're continuously producing the links to the government so that if people access our site, then they can go straight to the government site. Remember, there's lots of fake news out there. You've got social media, WhatsApp group. There's so many things. So what we are stressing is, please use the trusted resources, the government website or our healthcare professional bodies website to access the latest and up-to-date and accurate information. Using fake news, he said, she said, they said, it could be very, very dangerous to many, many people moving down risk. We've got videos, podcasts, etc. That you can see from there. As I've said, supporting returning to the front line and volunteering people. We've got posters for key workers. So we've had issues around people being assaulted in community pharmacy, being threatened. spitting on if they don't get their medication quickly. We've had, and obviously because of the high surge, so the Royal Pharmaceutical Society have put posters along with other healthcare professional bodies for pharmacists to display, please, this is a time when we need patience. We're all trying to work as best as we can. And now we've worked with police authorities as well, where if anybody is threatening or using any threatening language to pharmacy or pharmacy staff, then that becomes breaking the law, and they would be dealt with accordingly, really. We've also had the issue where healthcare workers, as pharmacists, as frontline people, incorporated into the National Health Service healthcare providers, where we get privileged access in terms of supermarket shopping, in terms of letters for nurseries as well. They want to put their childminders there. So all those during the process, so that we get some access quicker, and we don't have to wait as normal, really, only under this COVID crisis. Issues around dealing with dying people as well. It's important, how do we keep and support people who are at end-of-life care? These are the whole host of things. You can see the posters that we produce to support, so that we put it out in the pharmacy, and patients are now actually listening to that and reading that and understanding that and taking it on board, because there's been lots of harassment as a result of that. So managing conflict, school letters on the bottom right-hand side. We're now part of the mental health program of activities that we can access free mental health services from that perspective. We've also looked, if you look at the top left-hand corner, the Royal Pharmaceutical Society and the British Pharmaceutical Students Association, which is the equivalent to the Indian Pharmacy Students Forum, we work with, because we want some of our pharmacists and pharmacy students have come from abroad, and we want to make sure during this COVID period that there is an extension for their visas as pharmacists, and we've managed to push that through government now, and we've got extended visas for people who are working here. We're also including the death service now, and again, this is a push. The professional body that we, through the Royal Pharmaceutical Society, along with other pharmacy organisations, have continued to put pressure on the government. And what does this mean? This is an insurance scheme for people who have been working on the front line, compensated, that I think it's £60,000 that will be given if they've lost a family member, or if they've died at the front line, should I say, and their families would be compensated. Pharmacy is now included in that program, and that's just from last week. We've had clarity, pharmacy teams, and again, that goes to show the value, the importance that pharmacy now plays, and this is something that's recognised by everybody as frontline people, really. So that's the death on the service benefits to pharmacists from death, supporting unpaid carers to access medicines is something that's happening in Wales. And we also now remember our pharmacists who have died from coronavirus, and we put special tributes for them, because these are people who have died for our profession, and we want to acknowledge that. And that's something that we can learn, and we value our pharmacists, whether they're members of the Royal Pharmaceutical Society or not. But again, this is showing working together and being together, really. So I think capitalizing on learning for our future strategy, we take each piece. What have we got? Where are we? And what can we do? And I think there's a huge opportunity, and perhaps we could put some notes down and sharing. And I think there's also a wide opportunity for universities to become engaged in some of this, in terms of upskilling people ready for the next onslaught. And I'm working with the Pharmacy Council of India as well, to hope we can push some strategy across from that perspective, really. So what do we have? There's a greater scope for engagement and support. We have a huge role in public health. On the back of COVID, I've been talking about antimicrobial resistance. India has is the capital of antimicrobial resistance in the world. And I want all our pharmacists in India and pharmacy staff and healthcare colleagues and anybody that they know to look at the dangers of overusing antibiotics, inappropriate use of antibiotics, and not completing the course when necessary. And that's why we're in the problem that we are. And that's why, if you can share, Aarti, the link that I've given you to become guardians of antimicrobial resistance, it takes 2 minutes and you can download a certificate, and each certificate that's been downloaded by yourself, it doesn't cost any money, will be registered for India as part of the wider global effort in terms of reducing antimicrobial resistance. We want antibiotics to work. We want it to work today, not tomorrow. We don't want to wait for the new antibiotic to come out. We haven't got the time. So it's all because of resistance, and we need to curb that. And it's education. So pharmacy plays a big part in that. So through that, the number of people that will be antimicrobial guardians, and it's in conjunction with the IPA, the Indian Pharmaceutical Association as well, then we can share that wider, really, and make India the largest number of antibiotic guardians in the world, and to showcase that forward. Testing. We need to ensure, perhaps there's a role here for pharmacists to be testing, and perhaps for technicians to be going in India, for technicians to take the tests across. It's not something that the pharmacist needs to do, really. This is what I've been talking with the Pharmacy Council of India. But we're not at this stage from that perspective. But certainly we're at a stage where we want to push for pharmacists being able to test as well. When a vaccination program comes out, in the UK, we are allowed to vaccinate. We do a huge program for flu vaccinations, travel vaccines, etc., particularly in the winter months, where I think when the vaccination comes out, we want to be pushing forward that this is a huge role for pharmacists to play in getting as many people vaccinated as possible. Upskilling of the appropriate staff is key, because you can't just throw people in there. And I think you've got to realize that if you work with the doctors, your doctors, and you say, look, this is not appropriate, let's get a template together and show them, look, this medication has too many side effects, but we can do this. If you talk about hydroxychloroquine and the effects of, and even supporting them in taking their medication. How many people in India, I would like to think, have not taken their medicines now, and as a result have died through the COVID climate? Isn't that a role that community pharmacists can play a big part in? Isn't there some skilling that's required, and not just from a business perspective, that we have to look? But I think if we provide that professional service, then perhaps there could be some payment towards that. Multidisciplinary working collaboration with pharmacy organizations nationally and internationally, I see a huge scope. I want to work with India. I want the UK to work with India, and I'll continue as much as I can to support India from that perspective. My key point to you people is try and make the links with the doctors and nurses, and try and make it multidisciplinary, because no one healthcare profession is going to be able to deal with this, and no one healthcare profession is going to be address the inequalities in health that we have, as I've mentioned, through deprivation, through poverty, through lack of understanding, interpretation, and the messaging has got to be in a manner that everybody understands. You and I can read all this, but there is so many people, particularly in India, when a large proportion of the population are illiterate. How do you get those messages out to them? We have it here where there may be the Bangladeshi communities I've mentioned has the lowest level of literacy. The government messages, what we give, may not be the same in terms of their understanding. So we need to tailor those messages to that group and the other groups that have different levels of understanding, cultural beliefs, behaviors, values, so that we can get everybody on board. This is an opportunity, and I think we should make the most of it. As I've always said, and Virat Kohli says, let's keep going together, and let's do it for pharmacy. Thank you very much.
So there is one question from Mr. Samyak Nag. He's a MPharm pharmaceutics student, and he always asks very interesting question that I have observed in our webinars. So thank you, Samyak, for that. And the question what he has asked is, sir, do you think countries are fully prepared to face and tackle the post-corona challenges that will arise in the field of education and employment?
That's a very good question. That's a very loaded question. Field of corona employment, I think the opportunity is huge. You have to look on the basis that we haven't produced a drug yet that can treat corona. We haven't produced a vaccination that can treat corona. We haven't produced the full care pathway that we can support corona patients moving forward. As I've said earlier on, and thank you, that's a great question. My personal belief is 2020 is not just a new world, it's a corona world, because by the time we eradicate corona, who knows when that's going to happen? Who knows if it will happen? So let's make it a world that we can work with, but look at how we can utilize our skills most effectively. And perhaps that could bring us more armory in terms of other healthcare issues as well on the back of that. Public health. I would love to see pharmacists becoming involved in a public health program for people in terms of good hygiene, social distancing, wearing masks, things like that. What about cleaning in terms of antiseptic usage in areas where, in the higher social economic areas, it's fine, but in the deprived areas. What about the management through that, the higher risk, the vulnerable people, the elderly people? How far are you going to shield them? Are you going to keep them in the houses all the time? I don't think so. So we have to look at, and then what about the mental stress that these people will have by being cooped up in four walls for nearly 2 months or 3 months or whatever it's going to be? I mean, we don't know what's going to happen in the UK for the elderly, more vulnerable cases as well, really. So there is a support, there is a huge opportunity for pharmacists to do domiciliary visits and go to patients' home and work with them in terms of medicines management and supporting them. Because I would love to see the data of how many people are, during this period only, have failed to get their medication and taking their medication as they should have been in more ways than one, really. So economically, there's a huge opportunity from research. From an educational perspective, universities have got a great part to play, because this is all part of the upskilling program. And perhaps we can see a new pharmacy in India as well, in terms of how pharmacy is working and recognized and accepted, and also the public health aspect that we can have, perhaps in terms of even the vaccination program that I've mentioned, really.
Another question is there, sir, how comorbidities with severe disease outcome affecting viral pathogenesis in COVID-19?
Yeah, can I just come back to that earlier point you made, Aarti?
Yeah, sure.
We have made it absolutely clear that be careful, be careful in terms of how you make those antiseptic agents, washes, scrubs, etc. And you are actually getting those approved, because a lot of patients here are using what we call fake messages. Do this and do that and it'll be fine. I think it's important that you use the approved ingredients, and it's properly vetted, so for the safety from that perspective. Yes, there is an opportunity in many ways that you can see, but I think you have to be very careful how you do that. Don't just do it in your homemade factory or something like that. That's where my caution comes. Give me the question. The other question. Sorry, what was that you said?
Yeah, so that was like, if any other disease conditions are there, is it viral virus pathophysiology or pathogenesis is changing or not?
Yeah, so in terms of the effect that the COVID virus is giving, we don't know what it's actually doing at the moment to the various other diseases within the system, how it's working, and that's what they're looking at deeply. This is too early, and my only advice, the cautious advice, is just wait for the experts to bring out published papers, published evidence around how this is affecting. We've at the moment got people saying that that there could be some streams that it's affecting the minority ethnic group because of the high risk that they have. Is it? We don't know. We need the evidence behind that. So in terms of how it's affecting the pathophysiology of other conditions, we still need to work on that.
Moving on, there is one question from Mr. Kashish Garg. He's again 6th semester B.Pharm student, and he's asking that the economy overall world has fall down, and specifically the countries, specifically the developed countries, in terms he's talking made on US, failed to save the patients. Having your perspective, was the pitfall in those countries, and what can be learned out of this?
Oh, that's interesting. So I just got the lessons learned. The lessons learned are, if within the developed nations, lots of people are dying, that just goes to show one of the key things is, are they social distancing? And are they wearing the effective PPE? There's lots of PPE we had earlier on where we need to make sure that it was the right PPE and what level of protection it was providing. So I'm talking visors, face masks, and gloves and gowns, depending on whether you work in hospital or not as well, really. So I think there's a learning from that. I think there's a learning in terms of I think in the UK, the government has put a huge amount of pressure, and it's worked because the large, you've got over 80-something% of the population that have stayed home through lockdown, and we're providing the different services has helped. I think that if you look at the different service delivery patterns, pharmacists using their delivery services to go out to patients' homes, again, that stops people from coming out, for the vulnerable at least, and pharmacists can make the cautious approach in terms of how they're delivering as well, really. So people are not exposed unnecessarily. The other learnings are that we clearly find that we've sheltered the people with conditions, who are over 70s, obviously have been told to stay home for 12 weeks. People who have got cases such as where their immune system has been compromised, they could be on cancer therapy, for example. Those people are being told to completely stay behind with respiratory conditions as well. So I think it's identifying the right people that are most at risk and to deal with them. The problem that we have now, and this is my own personal worry, is we need a method to support those patients once the lockdown is eased, because what kind of support have they got? Are they still going to be able to go out? Is there some mental health issues that they've been dealing with as a result of being cooped up in the house, in the homes, and not being able to see people? And if they've lost somebody, I'm dealing with somebody, with my colleagues, etc., and how they're facing, and have they got the courage to come out? So I think the learnings are, the messages have been good. They could have been better. The messages could have been earlier, but we've got what we have. So we could have possibly learned from Italy much earlier. The PPE equipment could have been supplied much earlier, but the stocks, and making sure that the stocks are there. One of the other things is that we had enough capacity for ICU units, because we had hospitals being prepared, new hospitals for COVID patients, for ICU units, but we needed the resource, the staffing, and the capacity for that as well. So what we have learned is we're working as a team. More people are pulling in, and more people, and we're being supported by our professional body as well.
Question is, what certain points that can be compared, keeping in view with UK and India combating with COVID-19 based on healthcare management?
So keeping with UK and India, I would certainly want to think about diabetes is a big issue that COVID has certainly brought light to me. In the UK, just to give, sorry, what was his name? I didn't get the name of the person.
Kashish.
Kashish, in the UK, people of Indian, South Asian origin are 6 to 8 times more likely to have diabetes compared to the white European person, type 2 diabetes. So 6 to 8 times. So I'm of Indian origin, my risk is 6 to 8 times higher, much greater than the white person, my colleague in the next room, for example. So from that perspective, we need to make sure that management is appropriate. And through this messaging, perhaps we can learn to target these patients even more effectively, is one way forward. I think the other issue is, so lockdown could have been much earlier. I think it'll be interesting to see this phasing approach now. We've got the app, and I don't know how India are working with the app. So that is the tracing. So that's, we want, if we're getting people out, we want to see, can we find, so if I've been talking to you and I may have then said, oh, well, I've had COVID symptoms, then that app will be telling you, get a notification saying, we want to get you tested really. So you don't spread it to somebody else. So those are things that we can possibly learn. I think telehealth becomes another part. Telehealth has played a big part. People are being virtually seen. We're making consultations virtually. Pharmacists are zooming into patients. Doctors are zooming into patients. So perhaps in India, where you within pharmacists, you could be, you know, you talked about economy and money and things. Isn't this innovation where you can zoom into your patients and you can give them one-to-one service to care in your own language? That, you know, that could be a huge thing in terms of supporting them with their treatment. So telehealth has become a big part. You've seen the app that we've started for tracing, testing, and tracking. Again, perhaps this is something that's here to stay. We're going to use these apps more, and perhaps there's another opportunity here for using technology in a different fashion for different parts of supporting patients and treating conditions and managing patients better.
So we have one more question from Miss Rachel Suri. She's a PhD scholar, I guess, with Jamia Hamdard. And her question is, sir, do you think herd immunity concept could be effective for COVID in India? Because I know like in UK,
Yeah.
initially they were believing in this and they were following it. So what your take on that?
Because we didn't actually go in for the herd.
Further.
We thought about it. We were thinking we could potentially go into it but the volume of traffic that came wasn't going to work. The other thing about herd immunity is, Rachel, is it Rachel or Rachel? Rachel. Rachel. The other thing is, that's a really good question, because, you know, we have a belief that is, as you know, particularly within the South Asian population, that we don't want to take any medication. We don't like taking medicines at the best of time. And we always look at alternative medicine. I would want to be careful at this point on COVID from that perspective, because there is no alternative medicine that can do that. There is no evidence to show that for sure. We do need to know immunity is working, because we don't know enough about it to show that. Can we take the risk about this herd immunity business? So you're suddenly going out and you think, okay, I could be, and how long is that immunity going to last? And then they're still questioning whether the immunity, you could get the COVID virus again after that. And then the final point is, if this virus mutates, then are we going, is that immunity against that new variant as well? So I would want to, at this point in time, want to tread cautiously from a herd immunity perspective, from a personal perspective. We're certainly not using that method here. I hope that's helped, Rachel.
So there is one more question, and it is from Muhammad Fahimuddin. He's an assistant professor in college based in Dubai, and he's saying that, you know, question is that, you know, the presently in Dubai is implementing stem cell therapy for the treatment of COVID-19 patient, and India we are implementing plasma therapy. Can you please, give a take on this two different, the therapies in terms of stem cell as well as the plasma?
Yeah, so I don't know what individual people are doing, but I look, as a pharmacist, one of the key things that I even teach my students and always say to my fellow colleagues, if you don't know, say the answer that you don't know rather than trying to waffle your way through. This is not an area of my expertise for me to give a clear-cut answer from that perspective. I'm sorry, Mohammed.
Okay, there is one more question from Dr. Amrish Chandra. He's a colleague and a friend in AIP, and he's asking, are clinical trials with placebo patient unfriendly and cause of huge mortality? Is it the case?
Well, the conditions, the parameters have to be checked. What do they use? Who are the age group? All those different variables have got to be taken into account. And this is where the trials are important. You've asked a very good question. So suddenly we're making trials and we're making assumptions without the trials that this is good and let's go for it. But that's why it's going to take a longer period of time before we get some kind of treatment coming through that is safe, that is effective, and that actually does more benefit than harm, really. So I think it's important to look at other trials as well, rather than individual trials but there are going to be some risks. And again, that's the whole process of clinical trials, to start off small, to move it through, depending on how many side effects are being produced. So I would wait and see, really, but and it depends on which type of drug is as well.